distinguished delegates, ladies and gentlemen. Let's divert our attention to the representatives of Melia Purosani Hotel to brief us in regards to the safety procedures of the hotel through a presentation. We kindly request your full attention during this brief presentation.
Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. Welcome to Melia Purosani Yogyakarta Hotels. On behalf of management, allow me to deliver the safety induction before beginning the meetings. Something that we have to inform you. Now we are in the ground floor of the building Melia Purosani in the Amarta Ballroom. In these rooms, we already installed the life and safety equipment. There are the smoke detectors that will detect the presence of the smokes. So please do not smoking in the rooms. And also the paging annunciators that will announce every emergency situations. And also we also install the fire extinguisher surrounding the building and also fire hydrants. We have also the fire brigade team and emergency response team that stand by 24 hours. And for you that stay in the rooms, please read. We have installed the emergency evacuation route that will guiding you to the nearest emergency staircase. Please do not use the elevators if there is emergency situations. For Bapak Ibu who need the health checks, we have the doctor on calls, and also only 300 meters from here, the nearest hospitals. The name is Bethesda Lembuyang Wangi Hospitals. I think that's all for the informations. From this room, if there is emergency, the exit door in your right behind, and then go to the main glass door, turn left. We already provide the assembly point in the main parking area. Thank you very much for your attention. Hope this meeting will running smoothly and successfully. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Assalamualaikum warahmatullahi wabarakatuh. May peace be upon us all. Shalom, Om Swastiastu, Namo Buddhayo, Salam Kebajikan. A very, very good morning, Selamat Pagi, and a warm welcome, delegates, ladies and gentlemen, to the beautiful and historical Yogyakarta Special Region. And welcome to the pre-conference seminar on safe and resilient health facilities and infrastructure as an event program in conjunction with the second ASEAN Academic Conference on Disaster Health Management. Firstly, allow us to acknowledge all the honorable participants, esteemed speakers, joining us in person here in Yogyakarta, coming from all ASEAN member states and all invited partner countries of ASEAN, as well as our honorable participants and esteemed speakers joining us virtually from around the globe. Welcome. Ladies and gentlemen, we would like to kindly inform you that this meeting observes the no smoking policy based on the policy on ASEAN's smoke-free events for all health-related events as endorsed by the 11th ASEAN Health Ministers meeting in 2012. Honorable participants, esteemed speakers, delegates, ladies and gentlemen, allow me to introduce myself. My name is Rahmat Idris. It is my distinct honor to be your master of ceremonies throughout the pre-conference today. And now to officially commence the pre-conference seminar, it is my distinct honor to present to you Dean of the Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada, Yogyakarta, to deliver the opening remarks. Ladies and gentlemen, please welcome Mr. Yodi Mahendra Datta.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. A very good morning, everyone. Once again, welcome to Yogyakarta. Welcome to our pre-conference. Distinguished guests, colleagues, ladies and gentlemen, when I first read the topic of our pre-conference, safe and resilient health facilities and infrastructure, I just realized that I have a personal experience with this. Let me take you back to 2006. To be exact, May 26, 2006. Here in Yogyakarta, we woke up to a devastating earthquake with a magnitude of 6.4 and killed thousands of people. At that time, my wife happens to be pregnant with our first child. She ran, she fell, and she went into preterm labor. So we went around the city to try to find hospitals for delivery, which was very difficult because apparently practically all hospitals in the city were affected by the earthquake to various extent. We finally got lucky. I got in touch with a colleague, obstetrician. He guided us to a small maternity clinic. So we got the last vacant room there, and he came and he checked, and he said to us, well, the delivery will still take a few hours. Just relax. Here's a flashlight. Beside you is an emergency exit. If there's an aftershock and the building may collapse, just go out and run. That was not so reassuring. But fortunately, there were no major aftershock, and our daughter was delivered safely, and we named her after the earthquake. Now, looking back, that actually highlights the importance of safe and resilient health facilities and infrastructure, which we apparently didn't have. Safe and resilient health facilities is paramount. For within the walls of these facilities lies the bedrock of our ability to deliver essential care, especially in time of crisis. The challenges we face, be they natural disasters or unforeseen emergencies compel us to fortify healthcare infrastructure to safeguard lives and communities. Throughout this pre-conference seminar, we will collectively gain invaluable insight in developing and maintaining health facilities that can endure the harshest trial. We will discuss the integration of WHO Safe Hospital concept in relation to the Sendai framework. We will have an exchange of experience on how our ministries of health across ASEAN strengthen the management of emergencies and disasters in hospital. Hopefully, by discussing these issues, we will be better positioned to mitigate the risk and to enhance our capacity to provide uninterrupted and optimal healthcare services to those in need. Thus, I would like to express my deepest gratitude to all of the speakers, organizers, and participants who have contributed to making this seminar a reality. The collective wisdom and expertise that each of you bring to this platform are invaluable. So, on that note, I would like to wish you a fruitful discussion. Now, let me rephrase that. Instead of wishing, let's all contribute to make the discussion fruitful. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you very much, Dean of the Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada, Yogyakarta, Mr. Yodi Mahendra Datta, for the opening remarks. Distinguished delegates, ladies and gentlemen, moving forward, may we now request Director for Center for Health Crisis, the Ministry of Health of the Republic of Indonesia, to deliver his remarks. Please join me in welcoming Mr. Sumarjaya.
Ladies and gentlemen, before I start my speech, let's pray together for our brothers and sisters in Gaza. Hopefully, the attack in Gaza will end soon. Amen. Honorable Steering Committee of ASEAN Academics Network on Disaster Health Management, College of ASEAN Member States, ASEAN Secretariat, ASEAN Coordinating Center for Humanitarian Assistance, Chief Advisor of Japan International Cooperation Agency, and Project for Strengthening the ASEAN Regional Capacity on Disaster Health Management Project Team, World Health Organization, the United Nations Office for Disaster Risk Reduction, Dean of Faculty of Medicine, Nursing and Public Health University, distinguished ladies and gentlemen, Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera bagi kita semua. Om Swastiastu, Nama Budaya, Salam Kebajikan. Warm welcome to Yogyakarta, Indonesia. On behalf of Indonesia government, I wish to convey my highest appreciation for your presence today to the pre-conference seminar on safe and resilient health facilities in infrastructure prior to the second ASEAN Academic Conference on Disaster Health Management. Ladies and gentlemen, disaster events have the potential to cause disruption to the health service system, caused by damage to hospital, and other health facilities which result in disruption and or cessation of health service, a time when the need for health services in crisis. It is very necessary to build safe hospital facilities, especially in disaster and emergency situations, where these health facilities must be able to save lives and be able to continue providing essential health services to the community. Therefore, a campaign is needed to reduce losses in health facilities, building during emergency and health facilities, and disaster situation to protect the life of patient and health worker by ensuring the resilient health facilities. Ensure that due to disaster and emergency condition, health facilities and health services can continue to function, and improving the emergency management capabilities of health worker and related agency. Distinguished delegate, the free conference seminar on safe and resilient health facilities and infrastructure is one activity to implement plan of action leader declaration on disaster health management, which is Indonesia as lead country. The objective of this priority is to integrate the WHO Safe Hospital concept in relation to Sendai framework. In this half-day seminar, we will listen to the various concepts related to safe hospital from WHO and UNDRR. Moreover, the application of the safe hospital concept in several ASEAN member states. Ladies and gentlemen, the fate of our promising future rests in our hand. Our joint action today will matter much tomorrow to fulfill our Asian vision. And by working together, can we achieve a more inclusive, robust, and resilient region? So, with this, I now wish to formally open the free conference seminar on safe and resilient health facility and infrastructure. Once again, I thank you and have productive discussion. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you very much, Director of Center for Health Crisis, Ministry of Health, the Republic of Indonesia, Mr. Sumarjaya, for the opening remarks. Esteemed speakers, distinguished delegates, ladies and gentlemen, we are now embarking upon the first sessions of the pre-conference. We will touch on the integration of WHO Safe Hospital concept in relation to the Sendai framework. And to lead us through the first session today, allow me to introduce our moderator of the session. He is an orthopedic doctor who specializes in the treatment of spinal disorders and injuries. And he is also an expert in the field of pain intervention for patients with pain problems. It is my pleasure to invite onto the stage our moderator. Please give a warm welcome to Mr. Yuda Matan Sakti.
Thank you very much, MC. Again, we welcome all of the participants, honorary guests. And for the first session, I hope we can start to get the session rolling with quite a really interesting session regarding how to integrate WHO safe hospital concepts in relation with the Sendai frameworks. We have three marvelous speakers now with us. For the first speakers, I think we have to check with our information technique regarding whether Mr. Yannick Mikaut Marcote can join us, because 2 hours of our session will be delivered with Zoom, and then our last session of speaker will be directly here with us. So can we contact Mr. Yannick from UNDRR, please? Okay. We are now waiting. Okay. Hello, Mr. Yannick. We are still waiting for the audio now. Can you hear and see us clearly? Okay. This is actually one of the good points of our blessing in having a disaster in COVID. So now we are getting more used to having this kind of seminars. Okay, again, we hope we can connect with Mr. Yannick. Okay, Mr. Yannick, we not yet have your voice yet. Okay, Mr. Yannick. Please.
Colleagues on Zoom are listening to me or
Okay.
hearing me?
Now we can hear you. Maybe you can turn on the volume higher. Mr. Yannick will bring us the talk about Sendai framework related to healthcare facilities. So, can you test your voice again, Mr. Yannick?
Yes, thank you very much. Is it good now?
Yeah, I think we can hear you now. Okay, the time is yours, sir.
Excellent. So let me know if I can start. And I share some slides with your colleagues. Maybe they can upload the first slide. But in the meantime, distinguished delegates, ladies and gentlemen, I am pleased to join you online today. As mentioned, my name is Yannick Michaud Marcotte, and I'm pleased to be here to discuss about the safe health facilities with a particular emphasis on how the Bangkok principles can be applied to operationalize the health aspect of the Sendai framework, and to discuss, as we mentioned, about infrastructure and health facilities. So if you see the slides, maybe you can go to the second slide now. So I would like to start by reviewing quickly with you how the resilient health systems, infrastructures, and facilities are a critical component of the Sendai framework. The Sendai framework for disaster risk reduction was adopted in 2015 and is until 2030, and it recognized the strong connection between health and disaster and promote the concept of health resilience. Several of the 7 global targets stated in the Sendai framework are directly related to the health facilities. I would like here to illustrate it with 3 important examples. First is reducing disaster mortality. Clear target of reducing disaster mortality by 40% and the number of people affected by disaster by 20% by 2030. Hence, the importance of a strong health infrastructure and health facilities to achieve this important target. Second, it's substantially important to reduce disaster damage to critical infrastructure and disruption of basic service.
Mr.
And
Yannick?
this includes health facilities.
Mr. Yannick,
Health facilities as a hard infrastructure, but also health facilities as a basic service, also as a social infrastructure service. The development of specific guidelines and standards for the design, construction, and operation, including also self-aid facilities. Third, the third example is the the promotion of safety of health facilities and hospitals, which includes, for example, the development of disaster preparedness plans for health facilities. These plans should include measures to protect patients and staff, to ensure that essential services can continue to be provided and evacuate patients
I'm
if
sorry,
necessary.
Mr. Yani.
It is important to ensure that health facilities are safe and accessible to all people, even in the aftermath of a disaster. This requires investing in the resilience of health facilities and in developing and implementing disaster preparedness plans. So there are some important examples I wanted to share with you on how resilient health system and facilities are a critical component of the Sendai framework. I invite you now to show the next slide, the slide number 3 for our colleagues in charge of it. So as we mentioned, the Sendai framework was adopted in 2015. 1 year later, in 2016, an international conference was organized by the government of Thailand, UNDRR, and WHO in March of this year with around 300 participants from 50 countries and organization, and they recommend the Bangkok Principles. And this is the second point I would like to discuss with you today. The Bangkok Principles are 7 measures to prevent and reduce the risk of health emergencies. The overall principles of the Bangkok Principle is to stress the importance of a multi-sectoral approach for implementing disaster risk reduction, and that all relevant experts and stakeholders need to understand disaster risk and health impact resulting from unexpected disaster so as to be prepared and respond. The Bangkok Principles are global ones, but in the Asia-Pacific region, strong efforts are made to promote them. I invite you now to share the slide number 4. So as you can see in the Asia-Pacific, there are some important regional commitments on implementing the health aspect of the Sendai framework. And as you can see here, there's a strong political will also from government and practitioners in the disaster risk reduction community to promote the Bangkok Principles. First of all, in 2021, developed through a consultative process including governments from Asia-Pacific, United Nations agencies, NGOs, academia, and UNDR stakeholders, the Asia-Pacific Action Plan 2021-2024 for the implementation of the Sendai framework was developed, and take note of the importance of the Bangkok Principles. Also in 2021, Government of Asia-Pacific recalled during the 77th session of the Economic and Social Commission for Asia and the Pacific, ESCAP, the Bangkok Principle as a contribution to the Sendai framework to build resilient health system and facilities. And finally, thanks to a lot of your government, just recently at the United Nations General Assembly, the member states endorsed the political declaration of the midterm review of the Sendai framework and called all member states to invest in health system and apply the Bangkok Principle. Now that we understand the recognition of the Bangkok Principle, please let's have a deeper look at what it is and its impact on the health system and facilities. So, sorry for the sound. So slide number 5, please. So there's actually 7 measures that promote the Bangkok Principles. And if you allow me, I would like to share quickly each of them with clear, concrete action. So the first one, it's really to promote a systematic integration of health into national and subnational disaster risk reduction policies and plans. And as I said, there are different concrete actions that can be done for each of the measures, but let me share one for each of them. So for this particularly measure, the importance of increasing the participation of health sector representatives in multi-sectoral emergency and disaster risk management committees and platforms at all levels are very important. We cannot work in silos, all separated. So it's important for, as I mentioned, that the health sector representatives, you are very well represented at these different platforms. Second, we would like to enhance cooperation between health authorities and other relevant stakeholders to strengthen country capacity for disaster risk management. One concrete action is how to integrate disaster risk management into primary, secondary, and tertiary healthcare and related services, meaning that in your daily practice at all levels, the integration of disaster risk management is integrated into the health system. And the second one, which is very important for our conversation, it's to stimulate a people-centered public and private investment in emergency and disaster risk reduction, including, as it says, in health facilities and health infrastructure. Some key concrete action is really to strengthen the implementation of the Safe Hospital Initiative and also to apply the principles of building back better in recovery and reconstruction, and this, very important, in coordination with communities. So when we talk about building back better, it's also the hardcore of the infrastructure, but also the soft part of the infrastructure, and ensure that all these health facilities are available for all the members in the community. And most important also, a very important topic, it's to promote the investment in research and development and enhance innovation and the use of modern technologies to manage disaster risk reduction. The number 4, it's really to integrate disaster risk reduction into health education and training, as it proposed also by WHO for sure, and to strengthen capacity building of health workers in disaster risk reduction. The number 5, if you allow me, it's to really incorporate disaster-related mortality, morbidity, and disability data into multi-hazards early warning system, health core indicators, and national risk assessment. It's very important that, that health-related disaster losses that include illness, injury, psychological effect, as well as damage and disruption of health facilities and services are really taken into consideration in our database. As a scientific, you know how it's important to work with data, and this is something that we should keep in mind. Also, the number 6, so 2 more. So it's important to advocate and support cross-sectoral transboundary collaboration, including information sharing and science and technology for all hazards, including biological hazards. The kind of event that is organized today and tomorrow, it's an excellent example on this importance of transboundary collaboration, and it's a great initiative from ASEAN and all the governments and all of you. And finally, you know, one of the important principles of the Bangkok principle, it's to promote a coherence and further development of local and national policies and strategies. It will be on legal frameworks, regulations, and institutional arrangement. Some key concrete action is to create an enabling environment for coherence of policies and strategies of the Sendai framework for disaster risk reduction, but also other global framework, meaning the SDGs and also climate change adaptation like the Paris Agreement. So thank you very much for taking time to listen to me, as well as to take note of the Bangkok principles and how it is important to implement it, the Sendai framework. I would like to express my gratitude for your time and attention, and I'm very pleased to have been invited here today. As you know, UNDRR, my organization, serves as a normative UN agency. We don't directly engage in the field, but instead our role is really to provide frameworks and guidelines. Our hope is that through these tools, like the one I presented, government, academic institutions, and practitioners can collaboratively work to enhance the health and well-being of individuals and communities impacted by disaster. Thank you for your support in this vital endeavor, and wish you a great conference.
Thank you very much, Mr. Yannick, but I hope you can stay for a while. I think after the last session, we will have a question and answer. We will have a question and answer, but later after the 3 speakers. Okay, I hope the technician can solve the problem and we will have a better risk management for this presentation. Okay, however, we will go to the next session. Again, we will, can we give a big round of applause again for Mr. Yannick? Again, thank you very much, sir, from UNDRR, United Nations for Disaster Risk Reduction. Okay, the next session, again, we will have an online presentation given by Dr. Hari Kumar from India. talking about the update of Hospital Safety Index. So we know that Hospital Safety Index is one of the indexes that need to be applied in the hospitals to have a resilient hospital having a possible disaster. I think we can contact our IT. Is it okay? It's clear to play the video? Okay, we give the time to Dr. Kumar.
For Geohazards International as the South Asia Regional Coordinator. I'm making this presentation with support from my colleague Dr. Janice Rogers and of course the involvement of Dr. Ruben Samuel of CRO. So we'll be talking about the updates and customizations of the Hospital Safety Index in the Sierra region in the last few years. As you know, the HSI is a vulnerability assessment tool for hospitals. Originally, this was developed, in the Bajo region following the Mexico earthquake in 1985, and over several years of. Good morning. My name is Hari Kumar. I work for Geohazards International. Good morning. My name is Hari Kumar. I work for Geohazards. Good morning. My name is Hari Kumar. I work for Geohazards International as the South Asia Regional Coordinator. I'm making this presentation with support from my colleague Dr. Janice Rogers and of course the involvement of Dr. Ruben Samuel of CRO. So we'll be talking about the updates and customizations of the Hospital Safety Index in the Sierra region in the last few years. As you know, the HSI is a vulnerability assessment tool for hospitals. Originally, this was developed, in the Bajo region following the Mexico earthquake in 1985, and over several years of actions for safe hospitals from WHO. The Bajo HSI got modified for global use in 2014. And I and some of my colleagues were fortunate enough to be part of the discussions that led to the release of this very important document. And it is actually an assessment tool identifying major vulnerabilities in hospitals without getting into detailed structural calculations and analysis. It identifies the impact on service delivery from losses in future hazard events, and it supports decision making on the next steps for investments, either in strengthening our resilience of our facilities or getting into more detailed assessment. Consists of 4 modules. The first one dealing with hazards and vulnerability assessment. The second one on the structural safety with a scoring system. Module 3 has the non-structural safety of equipment, safety of the utility supplies in the hospital, etc. And the module 4 looks at the emergency management capacities in the hospital. Though this tool is supposed to be multi-hazard, it has a focus more on earthquakes and wind hazard, with also considerations, a few questions on fires and floods. It gives a snapshot of the resilience in future hazards. This tool was first field tested in the Solomon Islands. My colleague Janice Rogers was involved along with WHO colleagues, and I was involved in the second field test in Nepal, in 2 hospitals in November 2014. And the date is very important because this was this assessment and report submission happened just 5 months before the great Gorkha earthquake hit Nepal and affected these 2 hospitals. So WHO Nepal thought it would be good for us to go back and check. Good morning. My name is Hari Kumar. I work for Geohazards International as the South Asia Regional Coordinator. I'm making this presentation with support from my colleague Dr. Janice Rogers and of course the involvement of Dr. Ruben Samuel of CRO. So we'll be talking about the updates and customizations of the Hospital Safety Index in the Sierra region in the last few years. As you know, the HSI is a vulnerability assessment tool for hospitals. Originally, this was developed, in the Bajo region following the Mexico earthquake in 1985. And over several years of actions for safe hospitals from WHO, the PAHO HSI got modified for global use in 2014. I and some of my colleagues were fortunate enough to be part of the discussions that led to the release of this very important document. And it is actually an assessment tool identifying major vulnerabilities in hospitals without getting into detailed structural calculations and analysis. It identifies the impact on service delivery from losses in future hazard events, and it supports decision making on the next steps for investments, either in strengthening our resilience of our facilities or getting into more detailed assessment. Consists of 4 modules. The first one dealing with hazards and vulnerability assessment. The second one on the structural safety with a scoring system. Module 3 has the non-structural safety of equipment, safety of the utility supplies in the hospital, etc. And the module 4 looks at the emergency management capacities in the hospital. Though this tool is supposed to be multi-hazard, it has a focus more on earthquakes and wind hazard, with also considerations, a few questions on fires and floods. It gives a snapshot of the resilience in future hazards. This tool was first field tested in the Solomon Islands. My colleague Janice Rogers was involved along with WHO colleagues. And I was involved in the second field test in Nepal, in 2 hospitals in November 2014. And the date is very important because this assessment and report submission happened just 5 months before the great Gorkha earthquake hit Nepal and affected these 2 hospitals. So WHO Nepal thought it would be good for us to go back and check the 2 hospitals, do the assessment all over again to check the efficacy of the checklist itself and see what was predicted correctly in the first assessment and what was not. And this second assessment was very useful in the sense that it helped us understand the need for customization to Nepal conditions, which was actually recommended in the first assessment as well. And we also understood that if the assessment tool has to be used more, it will need to be in the form of a mobile application for use by the future assessors. So WHO developed this hospital safety index as a mobile application in 2019. And in addition to the WHO HSI modules, the HSI Plus module has a module on the development of the disaster management plan, the hospital incident command system, etc. in the application, which is why it is called the HSI Plus mobile. And this is well integrated into the hospital information system of the government of Nepal. And the customization needs identified in the global HSI, when we were looking at it from Nepal or the South Asia perspective, we saw that the list of global hazards, it needs local customization. And also there is a lack of a consistent or replicable method that addresses hospitals with multiple buildings. The HSI, one of the main drawbacks is that it considers a hospital as one building. And in Asia, most of the hospitals have at least a dozen buildings, and some even having more than 50 buildings in their campus. So we had to customize the checklist for addressing multiple buildings, many of which have very critical functions in them. And the structural module in the HSI was actually far less detailed than the screening tools that the Nepal engineers were using normally for assessment of normal buildings, let alone hospitals. And some vulnerabilities which were missed in the first assessment because the the checklist doesn't capture the vulnerabilities of partition walls and pipe bracing, etc. Were also something we wanted to add, and so the customization, which was supported by CRO and WHO Nepal office. In Nepal, we removed the hazards not present in Nepal and replaced the structural checklist with most parts of the locally used checklist, and included checklists for wind, flood, and wildfires also. And another significant change was in the non-structural safety, because we were looking at hospitals with multiple buildings, and so we had to split the checklist into two, looking at this facility-wide assessment. So we'll be looking, and in the facility-wide assessment, we'll be looking at the ease of movement of fire engines around the hospital campus. That will be a facility-wide question, whereas the safety of suspended ceilings in an operation theater would be a building-specific question. So we divided the checklist into two, and that was the 3A and 3B. The module 4 emergency management had small changes only, except that we added a checklist for assessment of access for differently abled persons. The scoring was made more complex because we had to look at building-specific weightages, as also the facility-wide markings. And the weightages were given to buildings based on the criticality of the functions that building was supporting. For example, an ICU building will carry more weight than a male ward or a female ward, for that matter. And all these weightages added to the facilities HSI score. This exercise in Nepal had a nice spin-off where Myanmar wanted to customize the HSI for themselves with support from UN Habitat of Myanmar, and hence this was completely inspired by WHO Nepal's customization, and we had to make necessary corrections for Myanmar as well, where we had to consider various levels of seismic hazard in Myanmar, various levels of cyclone hazards considering the country, whereas in Nepal we had the same hazard uniformly across the country. So with some changes to the Nepal customization, the Myanmar version of the HSI was also completed. These really taught us a lot of lessons. It brought about significant improvements for the global HSI, making it very locally acceptable, because we were following, in Nepal we followed the Nepal Building Code, and Myanmar we followed the National Building Code in Myanmar. So there was some trade-offs in the complexity, but we had much better information coming in. This became a much better decision support tool. We field tested the checklist HSI, customized HSI, in 5 regional hospitals in Nepal in 2019. However, we could not do the field test in Myanmar because the project happened during COVID-19, so only a virtual testing was done. And because there were so many fires happening in COVID hospitals at that point of time, there was also an expressed felt need to include fire safety in the checklist, which is probably why WHO in 2022 CRO called for competitive proposals for developing fire safety checklists for hospitals. And GHI got selected as the agency, and we developed 3 checklists. One checklist AA for self-assessment of fire safety in hospitals, mainly fire prevention kind of checklist, where the assessment is an internal assessment done by trained hospital administrators. And checklist B is most relevant for our discussion here, because it was a comprehensive fire safety assessment checklist which was in line with the HSI checklist. And checklist C was an assessment checklist for temporary or field hospitals. So the fire safety checklist B, in line with it, was based on the model of the HSI. It contains 44 questions and again divided into facility-wide assessment and building-specific assessment. And the field testing of this was carried out in 5 hospitals in Nepal and 3 in Maldives. And WHO Nepal also used this opportunity to update their HSI Plus Android application to include the fire safety checklist B into the app itself, so that now their assessment is more comprehensive. These are the snapshots from the checklist B. As you can see, it looks very similar to the HSI. The safety levels are similar. The weightages are slightly different, and you have the building-specific assessment as well. So this came with a training package. So we did the hands-on training along with the pilot testing in Nepal. And pilot testing was done in 2 hospitals, and the hands-on training was carried out in 3 other hospitals. And similarly in Maldives as well, where we looked at 3 different hospitals. So the fire safety checklist is really a very, very important addition to the global HSI checklist. The focus is on life safety, and the score for the buildings are classified. The weightages are as per mobility of the occupants. So where patients are less mobile, like in an ICU, the weightage is different from the patients in an outpatient department. And this checklist is currently planned to be field tested in other countries. And it will be a great addition to the HSI tool, which is already a very, very important tool that raises awareness during assessments. I have seen the eyes of the hospital administrators open up when they understand why we are asking the question about how many hours of generator backup does your hospital have. When they get to understand the why of it, it really is an awareness generation tool. So wider usage is needed of the HSI to enhance resilience of health facilities as they grapple with the vagaries of climate change and other hazards which are increasing by the day. Thank you so much for this opportunity to present in this excellent workshop. Thanks to WHO for the opportunity. Thank you.
Thank you very much, Mr. Kumar. I think we give a big round of applause. And take our last presentation, I think we can go more really the application of, we call it in Indonesia HDP, Hospital Disaster Plan. This is Dr. Hendro, one of our mentor, my personal teacher, mentor. He's a digestive surgeon, but we are often to go around in disaster. So we give a big round of applause for Dr. Hendro Wartatmo, talking about the integration of safe hospital concept with the Sendai framework. The time is yours, sir.
Yeah, thank you very much for all participants and also for the committee, for the time for presentation. Yeah, my name is Indro, and I don't think that one person in that room is older than me, because I already appointed as a member of 7-Up group. I already 71 years old, and I'm the witness of the big disaster in Indonesia. With Prof. Kai started in volcano eruption in 1994, and the latest one is earthquake in Cianjur, West Java last year. And the focus of my presentation in this time is how to implement it or actualize the concept of Sendai framework and also safe hospital from WHO, and the framework of hospital framework Bangkok. How to implement this? So it means that we should have a concept how to develop or provide a guidelines for the frontliners in disaster. Who is the frontliners? The frontliners is health facilities. Health facilities in my country, health facilities means hospital, maybe health center, or small rural hospital. All of this is the frontliners. But in this time, I will start to present my concept, how to develop it in hospital, because hospital in the future can be the model to develop this guideline in the lower level of health facilities. So because the majority of my presentation is already presented by the previous two speakers, I will start with slide number 8, please. Slide number 8. Number 8. Slide number 8. Aduh. Terus ke bawah lagi. Bawah lagi. Bawah lagi. Ke bawah lagi. Terus bawah lagi. Atas satu lagi. Atas lagi lah itu. Aduh. Sorry. Ya oke. Udah sampai di hospital disaster plan tadi. Hospital disaster plan tadi ya. Tadi ada hospital disaster plan tadi mana? Bawahnya lagi tuh. Nomor 9. Yeah, okay. So, I think disaster plan is hospital response of the hospital during disaster, and it must be well documented, because it will be the guideline for all of staff during disaster. So we should have standard hospital disaster plan. What is the material or component of hospital disaster plan must standardize. And the hospital disaster plan must be according to the accreditation standard. Slide. Yeah. So it is the message from the FEMA that hospital disaster plan must be accreditation consistent. It means because in my country there is a hospital accreditation, national hospital accreditation. In that accreditation, there is some point how to evaluate the hospital response in disaster. And also in hospital disaster plan, we should develop this. So these two things must be matched. So we work for one time for two objects. Slide. Yeah. In my country, hospital accreditation is proceeded by independent organization, And we have 6 independent institutions for accreditation, and we have 6 independent accreditation, so it's more objective. Yeah. So the standard module of hospital discharge plan must be matched with the national hospital accreditation. So we already start with this step. Yeah. Now we try to develop a standard hospital disaster plan, and we work with my institution, Center of Health Policy Management, and also with Association of National Hospital Association, or PERSI, and also with Ministry of Health. We already talked with Pak Jaya. Yeah, we try to develop a guideline to provide the frontliner how to respond in hospital, how to respond if disaster happen. By far, we have no guideline. Yeah, we have no guideline, we have no standard guideline, so every hospital has their own guideline. We try to make it standardized. Slide. Yeah, this is a comparison between hospital accreditation standard and hospital safety index. Yeah. So our guideline must be follow the concept of Sendai framework and also safe hospital from WHO, and also Bangkok framework for hospital response. Okay. Slide. So, as a resume, as my short presentation, hospital disaster plan is response plan for disaster situation. Yeah. This plan is actualization of the message of WHO framework and focused by Sendai framework. It must be developed correspond with national hospital accreditation. That's I will emphasize that we should provide a guideline for the frontliner, or make it a concept landed to the earth. Yeah. Not just only the concept, but the concept should land it to the earth. It means that the frontliner know how to operate this concept in the field. Yeah. That's all. Thank you for your attention. Yeah.
Thank you very much, Dr. Hendro. I think we gave a big round of applause. Dr. Hendro, can you join me here? Sorry, sir. To get question and answer, because we still have 15 minutes. We are really looking forward to have this first session to be more fruitful, because in here, I think we've already talked about how WHO create the standards, and then how the hospital safety index is being more or less getting to adapt with the local condition, and how we in Indonesia doing it by the assistance of Ministry of Health, doing it with hospital disaster plan. So we are really hoping for a discussion or question and answer. We also hope the IT can contact us with Mr. Yannick, so he can also appear on the screen, so we can take question and answer. Is there any question and answer from the floor, please? Okay, yeah, please, Miss in the back, please introduce yourself and your institution before you go ahead with the question.
Okay, check. First of all, I'd like to introduce myself. I am Alif Indira. I'm a research assistant from the Health Disaster Management in UGM. And I'd like to ask to all of the speakers that from your presentation, it stated that HSI, or Hospital Safety Index, has already known worldwide and also accredited as a tool for assessment of the hospital preparedness level. But up until now, there are still various tools being used by different countries. Some of them make the customization or make their own tools based on the HSI and implemented based on the culture of the each countries. So what's my question? There are two questions. The first is, what's your opinion about this issue? And the second is, how far is actually a country can make or adapt or customize the HSI tools to make their own tools, or is it actually prohibited to actually to do such things? Thank you for the answer. Thank you.
Okay, thank you very much. We go. Is there any other questions from the floor? Okay, please, sir. We will take two questions and then we go ahead with the answer. Please introduce yourself before you go ahead with the question, sir.
Good morning. I'm Eric from the Philippines. It was mentioned earlier about the importance of the community involvement in terms of the enhancing or maintaining the health system in terms of the safe hospital. So my question is, what role does the community engagement play in enhancing the safety of our facilities during disaster? And my second question is, how can the hospitals collaborate with the local communities for effective disaster response? Thank you.
Sorry, the first question, sir?
So my first question is about what roles does the community engagement play in terms of enhancing the safety of our facilities or our hospitals?
Okay, thank you very much, sir. So we go ahead with we have here Dr. Hendro while the IT trying to connect Mr. Yannick. Do you have Mr. Yannick here on the screen? Okay, maybe we go ahead with Dr. Hendro. How about the application of hospital safety index? Why is it really we still have different instrument? Maybe you can go answer it, Dr. Hendro.
Thank you. We don't have any standard, as I said, how to evaluate the safe hospital. And as far as I know, that hospital safety index is not implemented yet in the national hospital accreditation. So we try to start it by developing a guideline for hospital disaster plan. This is my answer. Maybe others can give the answer.
Okay, we have here Mr. Kumar. Do you get the question, sir? Hello, Dr. Kumar. Did you get the question, sir? Sorry, you don't have the sound yet? Okay, so we'll try to reach for him again. So how about the second question, Dr. Hendro? About the role of community, how to engage their role in yeah.
In my opinion, the role of community is more prominent in the pre-hospital phase, not in the hospital phase. In the pre-hospital phase, I mean in the field, yeah, the role of the community is prominent. And it's written in our in our constitution that the disaster response is the responsibility of government and community. Yeah. In fact, in my opinion, it's more prominent in the pre-hospital. Like in Merapi, yeah, Merapi is only the most active volcano in the world. It's just 24 kilometers from my home. Yeah. There are many of community group which prepare for disaster response, for evacuation, yeah, for socialization of the impact of the disaster and so on. Yeah.
Any other? Do you satisfied with the answer, sir? Okay, so again, engaging the community is more on the pre-hospital phase. And then I think for the hospital safety index already being mentioned. Is there any other questions from the floor or any comments regarding the answers? Okay, if not, maybe Dr. Hendro, we know that in Indonesia we have hospital disaster plan, and it is one of the requirement in Indonesia that each hospital have that and have the four basic based on hazard, structural, non-structural, and the management. But how do you think the government should? How do we collaborate with the government to implement the hospital disaster plan in Indonesian perspective?
Yeah, in my opinion, how to implement it, the hospital disaster plan is by provide a guideline, standard guideline. Yeah. And the standard guideline developed by government, the professionals, and the academician. So at least it must be 3 stakeholders to develop a hospital disaster plan which can operate it in the disaster situation. Yeah, the 3 stakeholders is the government, is Ministry of Health, and the academician like also Center of Health Policy Management in our faculty, and the third is the professional. Professional means the management of the hospital. Yeah, it's my opinion.
Okay, Mr. Yannick and Dr. Yannick, can you give a comment on that, sir? I don't think we can hear you, sir. The IT, is it possible to have question and answer? Yeah, now we can hear you, sir. Yeah, we can hear you now, Mr. Yannick. Yeah, about the implementation of HSI. Implementation of HSI, Hospital Safety Index. Okay.
Yes, do you hear me now? So I don't know if I can be here in the room. I would like to share some thought on the community engagement.
Yeah, please, sir. The community engagement, please.
So sorry, I will let you answer. Okay, so you hear me now?
Yeah, we can hear
Mr.
you
the
now, sir.
Facilitator, yes? Okay, thank you very much. Thank you very much, colleagues. So I would like to answer on the question related to the community engagement in hospital safe cities. And it's a very good question because I think it's very essential for building resilient hospitals, you know, and protecting the health and well-being of communities. There's no doubt that we have seen at UNDRR that when communities are involved in the planning and implementation on any kind of disaster risk reduction and response measure, they are most likely to be effective and sustainable. And I think it's the same thing with the resilient hospital, you know. So when there's a different way that we can engage the communities, you know, in hospital safe cities, just making some example right now, the communities can participate in some risk assessments and planning, you know, so they should not be only the seen as the customers, you know, of this, but also as the planners of this. Some community can help to identify, you know, what are the risks that some hospitals might face, and also to develop some plans to mitigate those risks, you know. Also, there's no doubt that volunteering has been shown as something so valuable for our society to develop our community also, but volunteers can be used also to support hospital when, in my case, you know, I'm with UNDRR, so I have everything in the lens of disaster, you know, but when it's time to prepare disaster and response efforts, very important to have volunteers that are part of this hospital safe, yeah. That's right. And maybe a last example, it's to educate the public in general about hospital safe cities, so we don't stay only around ourselves and our community of practitioners, but it's something that is public and where the community members, you know, could be used to raise awareness about the importance of hospital safety, and also to promote best practice and sometimes put some good pressure on local leaders and community leaders to ensure that this best practice are implemented and funded at the level of every hospitals. Thank you very much, and I hope the sound was good. Thank you.
Yeah, it's answered really clearly, sir. So, Dr. Kumar, do you have any comment or weigh in about that?
May I
sir?
come in to answer the HSI question? Am I audible?
Yeah, we can hear you clearly, sir.
Yeah.
Wonderful, wonderful. Thanks, Yannick. It is wonderful. I'm taking forward what Yannick had just mentioned about community. I'll just answer that question first. Very, very important role of communities, and you know, mostly what happens is hospitals do not really understand the role of the communities, and the community does not understand their role in the preparedness of the hospital. So, in many hospitals of late, they have started involving community in their preparedness planning, and as Yannick mentioned, it's the volunteers, and they are going to volunteer anyway. In case there is a fire in a hospital in the middle of the night, the first responder is going to be the community around them. But it is very important to let them know what their particular role will be. They may have a role in managing traffic, in you know, evacuation once the patients are outside, but they have to be told that role. So it is very important, as Yannick mentioned, that to involve them in the planning part itself and to understand which community is going to respond to any event in the hospital, and how they can be channelized, how their roles can be planned. And many hospitals I know now give free first aid training to the communities. It's a sort of a initial engagement with the community, and then they introduce the plan, and they give them, I mean, vests and caps so that they are identified, the trained ones are identified even when the response happens. That is to the question on community. About HSI and how it can be taken forward, I think the Southeast Asian Regional Office has taken many steps to customize HSI to the local conditions. It doesn't need, it's already been customized to 2 countries. And when we were engaged in the second country, we realized that it only takes a very minor tweaks to customize it for local conditions, and that has to be led by the local country offices and the local users of HSI. They have to lead it, but the overall facilitation can be by the regional offices. And you know, having used HSI several countries, I see this, I mean, it is an assessment tool, but I see it more as an awareness tool, because when we ask hospital administrators about how much power backup do you have, and then they have no idea when we are asking them the question, then they call the maintenance people and ask, how long will our generators work? and then they will calculate and say, okay, only 6 hours. That is when it hits them. That is when they realize how vulnerable they are. So these questions are in many ways an awareness generation tool as well for key hospital administrators. I think the way for HSI is to make minor tweaks and get it localized, with very much involvement of the country officers and the health ministries of the countries concerned. Thank you. I hope that.
Thank you very much, Dr. Kumar. I think the main point is to manage the risk, to manage disaster, I think. It's really, thank you very much, sir, in engaging communities, really. Is there any other questions from the floor? Yeah, please. We still have time. Yeah, please, miss, you can go in front of the mic. Please introduce yourself before you go with the question.
Good morning. My name is Melisa Rahmadani. I'm from Universitas Indonesia Hospital. As an occupational health and safety practitioners, I'm interested with the topic that Mr. Hendro delivered about integration hospital safety index with accreditation. As we know, hospital safety index included in element 9 of hospital accreditation in facility and safety management modules. So, however, the latest or the new assessment tools didn't include HSIs directly with the old one, previous tools. The latest tools only included structural and non-structural assessment. However, what is found in the field is that this assessment clause only stop at the HSE measurement as the Excel report. Even though filling out the HSI is in an independent assessment, further confirmation, I think it's really needed. But the one reason is that the competency of the assessor related to hospital safety index is still minimal. How do you respond about this, Mr. Hendro? Thank you.
Shortly answer from me that accreditation is a reduction of hospital safety index. So it's a spec down. Only a very few aspects of hospital safety index is evaluated by during hospital accreditation. We try to make it better. Yeah. So not only a few, but we try to add some point should be evaluate in national hospital accreditation according to hospital disaster plan or hospital response in disaster. Yeah. Thank you.
Okay, I think we can conclude this session. I think it's a really good question regarding application and then how we still fill it out as a administrative tool, not of a really implementing it in a way. However, we are moving forward. Again, the main take-home message is the role of involving everyone, and collaboration is the main thing. And I think as ASEAN, we can really proud to say that we are moving forward. Again, thank you very much for everyone. And then we give a big round of applause for our speakers, Dr. Yannick, Dr. Kumar, and Dr. Hendro, and all of you who already attend the session. Thank you very much.
Thank you very much, our moderator, Mr. Yuda Matansakti, and also our speaker, for guiding us through the discussions today. Kindly remain on stage, moderator and speaker. Would like to use this opportunity to present both of you our tokens of appreciations on behalf of the Ministry. And may we now invite Director of Center for Health Crisis, the Ministry of Health of the Republic of Indonesia, Mr. Sumarjaya, to kindly present the tokens of appreciations to our moderator and speaker of Session 1. Kindly, sir, join us on stage. And this is an expression of our deepest gratitudes for their insights and knowledge on the matter. The first sessions, integrations today of WHO Safe Hospital concepts in relation to the Sendai framework. First token of appreciation to Mr. Hendro Wartatmo, our esteemed speaker for the day. Thank you very much. And another one to our moderator, Mr. Yuda Matan Sakti, both amazing doctors here in Yogyakarta from Universitas Gadjah Mada. Our deepest gratitude. Thank you very much, moderator. And also to our previous speakers from UNDRR and from WHO. We also thank you. And now a moment of photos, please. We thank them both also for joining us virtually, and we hope to give you our tokens of appreciation in person should we see you here in Yogyakarta, Indonesia in the time coming. Thank you very much, Mr. Sumarjaya, Mr. Yuda Matan Sakti, and Mr. Hendro Wartatmo for an insightful session 1 of the pre-conference. Distinguished delegates, ladies and gentlemen, session 2 of the pre-conference is just around the corner, but we will now take a 15-minute break to allow you some time to enjoy coffee and tea. And we have put together and served your refreshments just outside in the pre-function area, and we will reconvene in 15 minutes around 10:15 local time. And in the meantime, we also request our panel of speakers for session 2 to kindly proceed to the right side of the stage and get prepared for your sessions. Ladies and gentlemen, please enjoy your coffee break.
อ๋อโอเคแต่ต้องไฟแต่นี่มันยังเป็นไฟเก่าก็ไม่เอออะไรต้องให้มันขึ้นถ้าเผาพอยต์อ่ะฟูPDF แบบฟูลสกรีนจะขึ้น
Your attention, please, delegates, ladies and gentlemen. It is almost time for session 2. May we invite participants of the conference to kindly return to the ballroom and take your seats. Once again, requesting delegates and participants of our conference to kindly join us in the ballroom and be seated, please. Session 2 is about to begin. Thank you. Speakers row. Take your seats. Once again, we are requesting our delegates and participants of the conference to return and be seated. Thank you. Distinguished delegates, ladies and gentlemen, welcome back. We hope that you're all refreshed and rejuvenated after the coffee break. It is such a delight to see you joining us back here in the conference room. We have now geared up towards session 2 of the pre-conference, ladies and gentlemen, which will shine a light on the topic knowledge and experience sharing in the ASEAN. The second sessions will be moderated by a representative from the Center for Health Crisis, the Ministry of Health of the Republic of Indonesia. Please join me in warm applause to welcome Ibu Widiana.
Well, good morning, everyone. I hope you are more fresher now and enjoy the coffee break, so we can start again for another interesting session in session 2. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi, salam sejahtera bagi kita semua. In this session, our speaker will present knowledge and experience sharing in the ASEAN and how is Ministry of Health strengthening the management of emergencies and disaster in a hospital. Well, before we start this session 2, I would like to introduce our great speaker. First, we have Dr. Ina Agustina Isturini from Indonesia. Second, we have Dr. Hairi bin Qasim from Malaysia. And third, we have Miss Florinda Fenzon Panlilio from Philippines. Fourth, we have Mr. Kasem Suk Yota Samut and Dr. Prasit Wuti Suti Metawe from Thailand. Before our first speaker gives the presentation, I would like to invite Miss Madelina Aryani from University of Gajah Mada to deliver result of rapid review. So please, Miss Madelina.
Yes. Okay, thank you so much, Dr. Widiana. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. I am Madelina Aryani. On my daily basis, I work as a head of Disaster Health Management Division, Center for Health Policy and Management, under the Faculty of Medicine, Public Health and Nursing, University of Gajah Mada. And I'm also currently assigned to work on point of action for Asian Leadership Declaration, target number 4.1.A, and this is our team. Ladies and gentlemen, this pre-conference session highlights the achievement of indicator 4.1.A outputs. The two indicators for first year 2023 include two main outputs, which are organizing seminars and completing the desk review. The desk review we are conducting right now is entitled Level and Tools for Hospital Disaster Preparedness in Asia. This is our outline presentation for rapid review. Yes, this is background and hypothesis. Starting from the integration risk reduction in the health sector in 2015 of Sendai framework, more and more hospitals are aware of calculating their level of disaster preparedness. However, we still find many tools to use. Based on this rapid review hypothesis is the level of disaster preparedness in hospital in the ASEAN and the tools is measuring hospital preparedness are still diverse. Rapid review question is, how is the hospital preparedness level and what are the tools used to assess the hospital preparedness level in the ASEAN? This desk review is carried out using the rapid review method, which was carried out within 2 months. The main objective of this desk review is obtain an overview of SAP hospital activities in ASEAN from 2016 until now. Equally important, this desk review also provides us with knowledge about the tool used to measure hospital preparedness for disaster. Our rapid review eligibility criteria are carefully summarized in this table. This is included studies, 12 full articles that have met the eligibility criteria and are written in English will proceed to the critical appraisal stage. The following are the rapid review results, and there are 12 articles accepted. 6 articles from Indonesia, 2 articles from Thailand, 2 from the Philippines, and the last 2 articles is from Malaysia. This result become the consideration basis of Indonesia to invite Ministry of Health representative from Indonesia, Malaysia, Thailand, and the Philippines. To this result, they will discuss the effort made by the Ministry of Health to strengthen safe hospital policies, regulation in their respective countries, including challenges and obstacles, as well as strategic plans. Another important finding is that the list of tools used is actually quite diverse. They use hospital safety index, they use hospital disaster preparedness tool, use hospital disaster risk reduction management, Thai hospital preparedness assessment tool for mass casualty incident and disaster, and some extraction on non-structural component from various assessment from the World Health Organization Europe region, from the World Health Organization Western Pacific region, PAHO, and WHO. One article of this study assessed the primary healthcare disaster preparedness level using hospital safety index. And 2 of this study were developing tools for hospital preparedness. That was my brief introduction regarding the result of the rapid review of target number 4.1.A, target activities which will be followed up later in this session too. Therefore, we hope there will be thoughtful interaction and all participants can provide input and explanation, brief stories about safe hospital items implemented in their respective countries during our discussion later on. I do hope that when capturing the safe hospital situation in the first year of 2023, we will get a complete picture that is nearly close to the actual situation in Asian countries. Following that, in the second year, which is in 2024, we will continue increasing the capacity. The topic of capacity building itself based on today's discussion. I would like to invite all the participants and the panelists coming today to start an engaging and productive discussion. Please, thank you.
Thank you, Ms. Madelina, for the presentation. And we don't have a discussion session. for this presentation. So we continue to our speakers who will deliver panel presentation, and each speaker we give time 50 minutes to deliver the presentation. After that, all participants can give intervention and response. For the first speaker, I would like to invite Dr. Ina Agustina Isturini from Indonesia, who will share about safe hospital policy and program in Indonesia. So please, Dr. Ina.
Very good morning. Assalamualaikum warahmatullahi wabarakatuh. Yes, I'm Dr. Ina Agustina. I'm a senior policy analyst and team leader of Evaluation, Rehabilitation, and Reconstruction of Center for Health Crisis, Ministry of Health. It's an honor for me to be here in ASEAN event. Since 2 weeks ago, I met some of the participants in regional collaboration drill in Kuala Lumpur. And now I'm here to share about the policy and program in Indonesia related to safe hospital. Okay. Okay, yes. As you know that Indonesia have so many big disasters experience, and based on Center for Crisis data for 5 years since 2017 until 2021, it was recorded that 41 hospitals damaged due to disasters. 12% of them were serious damage and couldn't function. The value of damage and loss, example for Cianjur earthquake a year ago, it's about 155.7 billion rupiah. And then in Lombok earthquake, it's about 68.2 billion rupiah. I think I have to calculate to dollars, yeah, but it's very big for, in rupiah, yeah. And in Central Sulawesi earthquake, tsunami, and liquefaction, it was a big disaster. It's about 170 billion rupiah. It's a very high value for damage and loss because of disaster. Hospital damage and disruption made a significant impact on the speed and accuracy of health responses during disaster situation. There be the potential increase in morbidity and mortality rates. Yes. Okay, here are the related regulation from in Indonesia. We have many law related to safe hospital, and I think it's takes more than 10 years ago. Start 2002, we already have a law about buildings. So buildings related to disaster risk reduction, so that the law regulate about that. And then after that we have a law about disaster management in 2007 and social conflict in 2012. And don't forget we have a law about health, hospital, and communicable disease, epidemic of communicable disease, about health in 2009 and hospital also 2009, and epidemic of communicable disease in 1984. And all of these laws already become one, and we update a new law in this year. In June 2023, we make omnibus law about health that already integrate all of the laws of health. So all of this law already explain more detail in our government regulations and ministerial regulation and technical guidelines. And for the new law, now it's still in progress to make the government regulation. But this law about health, the new law about health, continuing previous regulation regarding hospital preparedness for disaster. Okay. Yes. Here are the summary of national regulation related to safe hospital. Actually, we already have the mandate from the highest level of law, yes, especially from law about health and hospital, about health, that hospital must have disaster management system and must be ready to provide health services during disaster. And also, moreover, in law about buildings, there is mandate that every building must meet the requirements to deal with disasters. And in law about disaster management, give the mandate that the government is responsible to carrying out disaster reduction efforts in integrating them with development programs, mainstream in development programs. So I think it's a very strong mandate because from the highest level of constitution, yeah, the law. And then how about the standard? We already made the regulation about standard. There is government regulation for administrative and technical requirements that integrate disaster reduction. Yes, regulation for administrative and technical requirements for the building. Sorry, I think I missed the building word here. So the building, it's already the regulation in government regulation under the law about buildings. So every buildings must provide the requirements based on the government's regulation and integrate with disaster risk reduction. And then we already have safe hospital technical standard, which is regulated in technical guidelines. Year 2010, we already using WHO indicators of safe hospital. I mean year 2012, sorry. Year 2012 using WHO indicators of safe hospital, and we update in 2020 adapted hospital safety index. So we already have the technical guidelines about that adapted the hospital safety index, but as Dr. Hendro said, this is not enough. Maybe we need more detail how hospital to operationalize the guideline about hospital safety index. And the license, the establishment of hospital must have permits and administrative and technical requirements that integrates disaster reduction for structure and non-structured components. We already have the regulation about this based on our government regulation. And as Dr. Hendro said, we already integrate with, the disaster preparedness for hospital with hospital accreditation. Yes, emergency and disaster management has been part of hospital accreditation since 2011, using the HVA accreditation indicators or hazard vulnerability assessment indicators. Yes, and then for law enforcement, we state the law enforcement in our law that there is criminal penalties and or fines and or administrative sanctions for every institution or organization that build the buildings not achieve or not provide the requirements that need. Okay. And here are our programs, yes. And then in general, our national long-term development program and national medium-term development program support the implementation of disaster reduction and increasing the capacity of hospital. Yes, it's in line with hospital disaster preparedness. However, there has been no explicit mention regarding safe hospital. In line but not specific mention about this. And hospital disaster preparedness was one of the programs in Ministry of Health strategic plan for 2005 until 2009. Continue in 2010, 2014, our Ministry of Health strategic plan state one of the plan is to improve the capacity of hospital and community health centers in post-disaster rehabilitation was one of the programs. Yes, and then since 2011, Ministry of Health has conducted the health transformation system, and one of the pillars is improving the access and quality of hospital. So I think this is one important part to implement the safe hospital. And the goal is to achieve the health system resilience. And this year, Center of Health Crisis collaborates with Universitas Gadjah Mada and Samratulangi University have trained 100 participants as safe hospital facilitators, and this training is planned to be routine annual training. Yes. Okay, I would like to explain more detail about health system transformation, because I think this is a very important part that will support our program to implement the safe hospital. Yes, based on the pandemic, COVID pandemic in Indonesia and also global, so Ministry of Health learned many things, learned so much. Yes, and then we decided to implement the health system transformation. Yes, there are 6 pillars for the health system transformation. First, primary care transformation, and then secondary care transformation, including the hospital, and then health system resilience transformation, and health financing transformation, health workforce transformation, and health technology transformation. We have many programs to implement 6 pillars of health system transformation that will support those pillars. It's very important to support the implementation of a safe hospital. Yes, because we improve our technology, our financing, our health workforce, health system resilience, primary care transformation, secondary care transformation, so it will be integrated, become one, and the goal is health system resilience. Yes. We face so many challenges to implement the programs of safe hospital. First, still we need to advocate more, because there are lack of commitment from local governments to implement safe hospital. Many of them think that safe hospital is the responsible, only hospital owner responsible. But we hope we still advocate and socialize that it's not only the responsibility of hospital owners, but it's our responsibility. And the indicators of disaster preparedness for hospital accreditation hasn't been a determining factor in passing accreditation. That's the problem, because this is not the determining factor. So some hospital can pass this, can pass the accreditation without focus on the disaster preparedness. Still not the main indicators. Yeah. Hazard vulnerability assessment indicators that are used in hospital accreditation is not comprehensive yet. Yes, this is our challenge, yeah. But this is that we use in our hospital accreditation. Yes, and lack of trained human resources. Only a few that train about safe hospital, and the implementation of program tend to be unsustainable. Yes, as we see the programs 5 years about what, and then next 5 years maybe different programs not sustained, and then not become one long-term programs for safe hospital. We haven't had the long-term program for safe hospital. the guidelines haven't been well disseminated. Yes, many hospital. Yes, we have. I think more than 300, about 300. Not 300, more than 3,000, about 3,200 more hospitals in Indonesia. And we have about almost 14,000 islands. For those islands, it's our challenges to disseminate many things about the program, and lack of research related to implementation of the self-hospital program in Indonesia. Okay, here are our way forwards. First, strengthen regulation by including the government regulation draft that explicitly state the implementation of the safe hospital program. We still fighting for this and hope can be implemented in our government regulation. And review the existing tools and improve the research to find the comprehensive adapted tool that most appropriate to Indonesia condition. Improve the advocacy to related sectors and local governments. Improve the training programs and socialization of the hospital, including by utilizing information technology. Yes, and strengthen the collaboration with cross-sector, local governments, universities, and NGOs to implement some hospital programs. I think that's all from me. Oh, the bell already ringing. Next, yes. Thank you very much for your attention. See you. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Ina, for comprehensive presentation how MOH of Indonesia delivered many policy and program to support safe hospital in Indonesia. Now we continue to the second speaker, and I will invite Dr. Khairi bin Qasim from Malaysia, who will explain about strengthening the management of emergencies and disaster in hospital in Malaysia. So please, Dr. Khairi.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh, and a very good morning to all. Thank you, Madam Chair. So before I start, I'd like to convey our appreciation from the MOH Malaysia for the organizers, to the organizers for inviting Malaysia to share our experience in strengthening the management of emergencies and disasters in hospital. Okay. Right. So this will be the outline of my presentation. I'll talk a bit about our own Malaysia experience in managing some of the disasters that happened in Malaysia and its impact on the health services and the application of Hospital Safety Index in our MOH hospitals, focusing on the activities during the planning phase and the operational phase, and then the challenges and the way forward. Oops. Okay. Malaysia have been actually quite fortunate because we don't have that many experience in managing natural disasters. For example, like the volcanoes, the earthquake, but of course we also had our share. It's going back. Thank you. Right. We mainly face a lot of floods. Yeah, because of the rain, heavy rain, and also landslides due to the heavy rain. We did have earthquake before, but that was in Sabah. That was sorry. Okay. Yeah. Doesn't show on my. Can we go back? Slide. Yeah, some more. We try. What's in front in the display in front of me is not the same as that one. I'm not sure why. Okay. So, never mind, can we go to the next slide? I don't want to waste time. Right, so we have issues with structural collapse, talking about technology-related disasters. And CBRNE, there are some incidents. I think one of my colleagues will be talking later, I think on the second day of the conference, about the Sungai Kim Kim incident involving illegal chemical waste dumping in the southern part of Peninsular Malaysia. Anyway, we go to one of the floods that have been actually affected our health services quite major impact. Yeah, this is in Kelantan, which is actually in the northeast part of the Peninsula Malaysia, the yellow-coloured state there. Okay. All right. Okay. So during that flood in 2014, actually quite a number of our health facilities were affected. Yeah, 118 health facilities, whereby 57 facilities were flooded and submerged, while the other 61 were actually cut off from access. So these are some of the areas that was affected: the health clinic, dental clinic, yeah, in Kelantan. Okay, this is the state hospital for the Kelantan, and it was also having water going into the hospital. So they had to move out during this time. But luckily, in the same capital city of Kelantan, is Kota Baru, they have another hospital, which is the university hospital. So they managed to transfer some of the patients to that hospital. Okay, this is another hospital, also a major specialist hospital in Kuala Krai, which was also affected during that 2014 incident, right? The clinics, which actually suffered total loss, yeah. Okay, but some of the things that were unexpected was that in this hospital Kuala Krai that I showed just now, even the flood victims were actually coming to the hospital to get aid, not looking for health services, but because they don't have any other place to go. So the hospital had to provide food for the flood victim, yeah, instead of the usual Department of Welfare. Okay, so these are some of the challenges that they faced during that time. There were so many flood victims crowding in the hospital compound. Yeah, even the health clinics, some of the health clinics which were not affected, they were using the health clinic as a temporary shelter for the flood victims. Yeah. Sorry. Okay. So one of the things that were mentioned at the time were the lessons learned. Of course, is the sustainable health facility, where these are some of the things that must be addressed before other major floods happens again in the Kelantan state. Okay, this is disaster within the hospital itself. This is in Johor. That is the Johor Bahru, which is the southern part of Peninsular Malaysia. So basically, the capital city of Johor is somewhere bordering to Singapore, actually. Yeah, I think the Singaporean, they know about this, right? So a fire broke out in the ICU, and this building, the hospital actually was built in 1941, which was about 80 years ago, right? So they had, unfortunately, there are some victims, yeah, I mean, who died, yeah, in the ICU because of the fire itself, right? So, and it's actually quite near to the emergency and trauma department for that hospital. So they had to evacuate even the patients in the emergency out because it's not a safe area at the time. Okay. So luckily, they had been doing quite a lot of their field exercise for internal disaster. So they managed to open up quite a lot of tents and move out quite a number of patients during that time. They are able to save, I think, otherwise there would have been more casualties in that fire. So they were luckily because they had that plan in place. Next slide. Yeah. Okay. So they had to open up in a compound just, I think, opposite to the emergency department in a parking space. So they managed to move all the patients from the danger area. Next slide. Okay, just to show you. Okay, next slide. All right, so when we talk about the hospital safety index, I think this was the the earlier version. It talks about the structural, the non-structural, and the functional. Right? So the structure, we're talking about the location, design structures, non-structural building, drawing plan, architectural elements, safety and security. Functional, talking about the internal circulation, equipment and supply, logistics, right? Human resource. So in the Ministry of Health Malaysia, actually, all this is being looked into by quite a number of divisions in the MOH Malaysia. For example, in the planning division, who actually plans before the hospital is built, where is the location, where they have some criteria to make sure it is not located in a high-risk area, yeah. And then the engineering, looking at the design, the structures, yeah. And the medical development division is the one that looks after the functional part of the activities. Yeah. Even our public health division is also plays a part in looking at all these things, and our pharmaceutical services division. And all this actually, they will liaise with the relevant agencies, for example, the Ministry of Public Works and the Fire and Rescue Department. Yeah, when they talk about the safety of the safe hospital. Okay, next slide. Right, so in the planning phase, the site selection, risk assessment, flood prone, accessibility, the Public Works Department and the facility designer, the hospital builders actually will look into all this to make sure that before the hospital is built, all this has been looked at. Next slide. Right. So in terms of regulation, we have this uniform building bylaws. It is not specifically to hospital itself, but part of the UBBL, we call it. It was produced in 1984. Last amendment was done in 2 years ago. You talk about the fire safety. What are the requirements in terms of installation, smoke detectors, fire doors, emergency exits, and the fire alarm system and extinguishment system. Yeah, the portable extinguishers, sprinklers, and all that. Okay, next slide. Okay, so an MOH part, what we have is actually the hospital's technical specs. Yeah, this part, hospital technical specs, where, for example, the emergency department, they must have dedicated isolation room. The radiology department must have a barium plaster for walls around X-ray room. So all this is actually under the hospital technical specs. So it will be given to the hospital builder, and they must comply with this requirement. And within the perimeter of the hospital, for example, there must be a minimum of 2 access routes, dedicated water tank that will allow 2-day supply, dedicated electrical substation and generators. Next slide. Okay, so during the operational phase, meaning the hospital has already been built, of course we need the emergency and disaster plan. So at the national level, we have the national guideline for internal disaster, which will be done specifically for the hospital. For example, this is for this is for Johor. Talking about the flood, how to manage if there's a flood happening in this hospital. This is for the pharmacy, talking about during disaster, how will the pharmacy division continue their service, and even department-specific plan. For example, this is pathology, where they deal with chemicals, so they have their own specific plan on how they will manage during the incident. Next slide. Okay, just to share, talking about the National Internal Disaster Plan, you can see that some of the things that's mentioned actually is the organization structure of the hospital committee, what are the activities needs to be done in prevention, preparedness, response, recovery phase, and talking about the specific disasters, unique, for example, for fire, for flood, earthquake, and CBRNE incident. Okay, next slide. Okay. The other thing I need to mention is that in the hospital service, we have the private companies which actually outsource some of the services, for example, the cleaning, the linen, the waste management, the biomedical engineering, and the facility engineering. These are two of the examples of the private companies managing. In my hospital, it's being managed by this Redicare company. So as part of their contract, they have to prepare a contingency plan to ensure the services are not disrupted. It's called Hospital Specific Implementation Plan. Okay, next slide. All right, so for example, if there's a power outage, they must already, for example, generator must be able to last for at least 48 hours. They must have enough fuel for that. Color-coded power outlets, yeah, for example, this is normal, this is the essential, where this is being, if there's no power, then the generator will supply to this essential. this is UPS. Okay, I think I don't have enough time. Okay, next slide. All right, okay, so even for medicine and consumable, they have special arrangement with the suppliers to provide buffer stock for at least 3 months. That's part of the contract. And some infrequently used stockpile medicine, for example, antidotes, they are stockpiled in certain hospital, which can be accessed by other hospital. Next slide. All right, so training, of course, is very important. So this is my own hospital. We had this chemical incident where we do a field simulation exercise. This is an annual event for us. Next slide. Right. This is actually dashboard for disaster risk profiling, talking about each district and what are the human resource available. For example, the human resource, the equipment, all this actually is being monitored by our CPRC, the Crisis Preparedness Response Center, or our health EOC. Okay, next slide. So challenges actually is, of course, to review the existing policy because we don't have that many disasters. So we need to continuously update. Getting funds to upgrade existing hospitals is another issue, right? And of course, we must make sure we maintain a safe and effective treatment even during disaster to our patients. Next slide. Right, our health workforce, of course, needs regular training because we have a very high turnover of human resource. And of course, we want to make sure for the medical vaccine must have equitable access to all. And the health information system, we need to enhance our current disaster risk dashboard, the MyCPRC that I showed just now. Next slide. Okay, last. Okay, way forward. We need to continuously assess and improve the Safe Hospital program by learning from incidents and not just our own experience, maybe from our neighboring countries, which that's what we are doing now. We are sharing all this. Regularly assess within the own hospital to take steps to mitigate, and once we have done that, we can update our emergency response plan accordingly. And of course, after that, we need to provide ongoing training and education for all staff. Next slide. So this is just the acknowledgement slide to all my colleagues from all this division, actually, who provide me with all this information. So with that, thank you very much to all. Okay, Assalamualaikum.
Waalaikumsalam. Thank you, Dr. Khairi, for interesting presentations. Yeah. Now we continue to our third speaker. I invite Ms. Florinda Venzo Panlilio, who will share about Philippines' experience in hospital safe from disaster. So please, Ms. Florinda.
Thank you very much, my dear moderator. On behalf of the Philippine team, it is my pride to present Philippines for the Hospital Safe from Disaster program, meaning to say that if a health facility has this in front of the building, it's committed to support the program. And the goals are very clear to read. There was contests or competitions on layout, designs, and templates for hospital safe from disaster, and of course, the signing as well as the reciting of the pledge of commitment in support to the program. Next slide, please. So in 2018, aside from the summit we conducted with the academe, we also had the summit which was participated by the private hospitals and local government units. This is to make the hospital safe from disaster campaign supported by the local government units all over the country. Next slide, please. So as I have mentioned, we continue orienting hospital personnel on the use of the Hospital Safety Index tool in order that they will adopt it in their hospital planning. Next slide, please. Next slide. Okay, we also had training on hospital assessment, and the output or deliverable of this training is a plan for the hospital. We call our plan not hospital disaster plan, but a disaster risk reduction and management in health plan for the hospital, because we are supporting the Sendai framework on the 4 thematic areas. The plan has the prevention, mitigation, preparedness, response, and recovery to rehabilitation strategies. Next, please. The inclusion of the Hospital Safety Index tool was also in the Green Viability Assessment tool, and this is now being promoted by the Health Facility Development Bureau of the Department of Health for adoption in the whole country. Next slide, please. We had partnership not only with the Department of Science and Technology for the databasing of the fault lines, but also with the Department of Public Works and Highways, simply because the structural engineers of the Department of Public Works and Highways are the ones helping us in doing structural assessment. Next, please. We develop important projects and initiatives like the planning guide, simply because the Dreamage Plan or the Disaster Risk Reduction and Management in Health Plan, which I have mentioned, is part of the hospital licensing and renewal of licenses. That your license will not be approved, will not be renewed if you cannot present the updated plan. We also conducted researches on hospital capacity assessment, focusing on important hospitals, level 3 hospitals at that, in order that this can be used in the planning. And we conduct hospital drills integrating mass casualty management, as I have mentioned. Sorry. Next slide, please. This is the mother policy of the Hospital Safe from Disaster program. It was issued in 2013. And please take note that it is aligned to international and local frameworks. In addition to this, in the next slide, you will see the different department memoranda, department personnel order, and the department order issued. Next slide, please. In support to the program. That the review, testing, and updating of the plan will be continued, that the assessment will be pursued as in compliance to the requirements, and then, of course, the designation of people who will lead the program in the hospital, in all health facilities, including the treatment and rehabilitation centers, and, of course, the funding, which is an important component in program management. Next slide, please. During the COVID-19 pandemic, part of our response is the issuance of the department memorandum, the Hospital Preparedness and Response Checklist, in which the hospitals were all mobilized to do assessment in order that we can be better prepared for the surge of cases. Next slide, please. Please remember that the Hospital Safe from Disaster program, as I have mentioned, is aligned to the Sendai framework, to the National Disaster Risk Reduction and Management Plan of the country, and the thrust of the current administration, the 4th agendum of the 8th agenda, bawat komunidad handa sa krisis, or all communities are prepared to crisis. Next slide, please. These are other issuances in support to the finalization and the conduct of electronic courses. We are happy to inform the body that we already have published 2 important courses. Next slide, please. One is the executive course, and the other one is a managerial course. So these are intended to increase the understanding and appreciation of the hospital executives and managers on Hospital Safe from Disaster program, and of course to develop competencies within hospitals, including local government units, to manage the disaster risk reduction and sustain hospital functionality. Next slide, please. These are just the content of the courses. For the executive course, we have these 4 modules. And next slide, please. The specific content of these modules are in here, the different sessions, ending up with tabletop exercise. The managerial course, on the next slide, please, has 5 modules with 23 sessions, and the end or the deliverable, the end point of this, of the attendance to this training will be a draft plan, a draft disaster risk reduction and management in health plan for the hospital. Next slide, please. So these are the specific content of the managerial course. Next slide, please. So the features of these 2 courses, The assessment tools and templates are downloadable. They are made or prepared with participants' manual to standardize the conduct of training all over the country. And there is that forum discussion slot in order to enable the interaction between the course administrator and the participants. Next slide, please. This is downloaded in the DOH Academy platform to enable the access of a self-paced attendance to the training, although synchronous sessions can be also conducted. Next slide, please. Among the challenges on the area of leadership and governance, there is the separation of the Health Facility Development Bureau and the Health Facility Enhancement Program Management Office, and this compromises the full implementation of the Hospital Safe from Disaster program. The Hospital Incident Command System is not fully functional in selected hospitals, and all the hospital physical structures have incomplete documents, so that the renovation, the retrofitting is quite challenging. On the health workforce, the retirement transfer reassignment of technical working group on the creation of tools and training is challenging, really. Limited dedicated manpower in the hospital to serve as resource person during training, to fast-track the cascading and rollout. There is a fast turnover of designated RIMH manager in the hospital, and there is an ongoing competency building among hospital personnel. Next slide, please. The on-service delivery, course administration requirements for cascading the hospital safe from disaster training, the updated one is still ongoing. There is a competing demand for the recovery and rehabilitation from pandemic simply because there is a delivery system transformation. Completion rates and status of the health facility enhancement program is taking a little bit slow, increasing demand for managing threats of all types of hazards. On health information system, there is a need to update the DREAMH plan and the need to improve information management in the hospitals from assessment to program implementation and review. On the way forward, on the next slide, please. Still on the challenges, access to essential medicines, there is a delay in procurement, difficulty in establishing forging partnership with partners. On the financing, government rate for honorarium to technical resources is too low, and low salary grade among hospital personnel. There is a delayed release of incentives and other forms of allowances. And we are now coming to the end. On the way forward, please bear with me. Next slide, please. We need to establish hospital safe from disaster training focals per facility with the concurrence of the DREAMH managers and the respective medical center chief. Support the maturity level indicators for the countrywide implementation of the universal healthcare, because this training, the hospital safe from disaster training, is among the maturity level indicators. Fast-track the uploading of the e-learning modules in the DOH Academy platform for complete access. Continuous updating of database of trained facilitators and personnel. Maximize use of technology to further advocate the training on hospital safe from disaster. The continuous allocation of funding to support the hospital safe from disaster program. And we need to intervene in the DOH on the retrofitting, renovation, and rehabilitation efforts of the health facilities all over the country as necessary. With that, on behalf again of the Philippine delegation, maraming salamat po. Thank you very much.
Thank you very much, Ms. Florinda, for wonderful experience from Philippines, how to manage and increase capacity of hospital to save from disaster. Well, I hope you are still enthusiastic because we still have two interesting presentation from speakers from Thailand. I invite our fourth speaker, Mr. Kasemsuk Yotasamut, who will share experience about safe hospital for disaster in Thailand. Please, Mr. Kasemsuk.
Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Selamat siang and a very good morning to everybody here. I'm Dr. Kasemsuk Yotasamut. I'm an emergency physician by training, currently at the Department of Medical Services, Ministry of Public Health. So I will be talking first part for around 10 minutes, and then I will pass the microphone over to Associate Professor Dr. Prasit, who will continue with the presentation. First of all, I would like to say thank you for inviting Thailand to share our experience on Safe Hospital. So next slide. Yep, so okay, just go on first before the slide comes up. So compared to other ASEAN member states, Thailand is a bit lucky that we don't have much of a catastrophe at the level of a disaster. The disaster meaning that the need exceed what we have, the resource. So we did have some disasters in the old days. 1962, we had the tropical storm Harriet in the southern part of Thailand that took life around 900 people. And then the most recently, we had a big disaster in 2011. There was the flood in most of the provinces in Thailand, I think around 60 provinces, that claimed the life of around 800 people. So those were the major floods. And who could forget the 2004 Indian Ocean tsunami? Next slide. Yes, Indian Ocean tsunami that claims life of thousands, both Thais and foreigners. So these are the few major disasters that we have in the country. But next slide. We do have a lot of other emergencies that happen around the countries. Although we are safe from natural disasters mostly, but we do have certain man-made disasters, not disasters, I can say, it's emergency situations like the political protests in 2010s, 2015, somewhere around there. And also, recently we also have the fire in one of the nightclubs that claims life also. So all these events, whether it's disaster or emergencies, does have an effect on the hospital itself. So that's why it's important to maintain the hospital. In any situation, the hospital must be maintained so that care can be provided. Because in time of disaster and emergency, the patient doesn't stop. They actually increase. Next slide. So the Ministry of Public Health divide emergency into 5 types that affects the health system. Number 1 is infectious disease. Number 2, man-made events such as terrorists or political protests. 3rd is natural disaster. 4th is chemical events. And the 5th one is the radiation and nuclear events. We've been through all of these events. The 5th one, radiation, we've been through recently also. There was a leak of some radiation material. But at the moment, lucky, we don't have any nuclear events yet. Next slide. In terms of law and regulations, there is no clear-cut law or regulations concerning safe hospital. There are some parts of acts like this one or plans that touches a bit on safe hospital. We do have the National Disaster Act and also the National Disaster Plan, which touches on the safe hospital a bit. Next slide. The content is in Thai, so I'm going to translate certain parts that relates to the Ministry of Public Health. The Ministry of Public Health being the primary organization responsible for the health sectors. There's mentioning of 2 parts. Number 1 is that to prepare health facilities at all levels for disasters. Number 2, as you can see highlighted, is to the establish of something called the BCP or the Business Continuity Plan. Next slide. So in Thailand, we have the Emergency Care System Framework, which is based on the WHO. Next slide. But we added 2 more components. One is a safe referral system, and another one is a mass casualty incidents and also disaster preparation. Next slide. We have an assessment of the ECS system that we implemented. It started, I think, around 2009 and updated 2016. So these are the components inside this book that we asked the hospital to assess themselves. And you can see one of them is the mass casualty incidents and the disaster management. Each of the components have subcomponents, and each of the subcomponents we also further subdivide into 0 to 5. 0 being you don't have that service, while 5 being like you perfect, you're the role model. Next slide. So in terms of mass casualty and disaster, you can see that there are around 4 components: mass casualty incidents preparation, disaster preparedness, response, and recovery. In disaster preparedness, you can see that there are a lot of things that is related to hospital safety. Next. These are some of the things that we do to make the hospital healthcare personnel aware. We have a few things. We have a few training. We have a few tools. In the response section, we have the training of the medical emergency response team, the MERT, that was established since 2008. This one is quite robust since we do it every year and we train people around the countries. But other things, we are still at the young stage that we are still continuing to develop. Next slide. We have the Hospital Safety Initiative, which based on the 2P safety, the patient and personal safety, which operates at time of normal and also at time of catastrophe. Next, one of the tools is the Hospital Safety Index, which we, based on the WHO, we translated and made it more concise, which I think Dr. Prasid will talk more on the hospital safety tools later. Next slide. We also had the training for something called the HOPE program, Hospital Preparedness for Emergency, which we collaborated with the ADPC or the ASEAN Disaster Preparedness Center. We started in 2012. We had the basic course and also the training for instructor. Next slide. So this is an example of the HOPE model. Next slide. This is a training that we did since 2012, and then the last training was in 2018. After that, we were struck with a few events and also with the COVID, but we are resuming the training. Next slide. So the HOPE course is not only in the basic training course, it is a continuation. You continue with the hospital assessment and risk evaluation. This is like the hospital safety that we need to focus on. Then we have the HICS or the Hospital Incident Command System. And last is the full-scale drill. Next slide. So that was the HOPE. And recently we had the COVID. COVID was bad, I'm sure, but it also brought some good stuff like we mentioned earlier, telemedicine, televised, Zoom and all those kind of stuff. For Thailand, we had something implemented during the COVID, which was the business continuity plan. Next slide. So in the business continuity plan, we want to make sure that the business, which is our service, hospital service, continues running. By the meantime, next slide. If you can move the slide. Yeah, thank you. So the concept is to maintain hospital service, maintain essential health care services so that people can still be treated. The importance of BCP is to reduce disruption, reduce the effect of the disruption, which is mortality and morbidity, and also to promote rapid recovery once the crisis is over. Next slide. So this is a framework, just an example. Okay, continue. Next slide. Okay, this is also the concept that we had. Sorry, it's in Thai. Next slide. And this is the form that we asked the hospital to fill during the time of crisis at that time. They had to submit their resources to the Central Committee every 2 weeks so that we know how the hospital are doing and we know where we can help in this situation. Just for your information, we implemented the BCP during the time after the first wave of COVID, because after the first wave in Thailand, we had 0 cases at that time. So we used that time and then we implemented as fast as possible, and so that you can be used in the subsequent wave. Next slide. Okay, so this is a picture of the BCP training. We did it at the ministry at the central level, and also we did like a telecast training throughout the provinces. Next slide. Okay, so this is a mass casualty drill, which incorporated the emerging infectious disease. Next slide. So challenges, definitely there will be challenges coming concerning safe hospital. We are not perfect. We are far from perfect. So there are a lot of things we need to tackle, which we need to know the challenges. Next slide. I think the number one is the leadership and governments. I think a lot of people will say the same for me, with me, because sometimes the executive, the higher level, they always seem to be changing, because sometimes end of the fiscal year, they move here, they move there, okay? Or sometimes we have a general election recently, so we changed the policy. So these people are the one that holds the policy and they guide us where to go. So if they keep changing, sometimes the policy, the focus policy will change. Financing will also depend on the policy. If the policy is not strong on this matter, financial will be lessened. Health workforce, the healthcare personnel are quite overloaded. And the thing is that safe hospital may not be something that they're focusing on. And the last is the information system. We have many hospitals and it's not only under the Ministry of Public Health, under other sectors. So sometimes information sharing can be a bit difficult. Next slide. So the way forward, I like to use 3 phases: sustain, accelerate, innovate. It's not my own phrase, it's something used by the WHO. Sustain, whatever is good, you continue it. One thing is to continue monitoring all the key performance index, all the reports. These need to be monitored. Second, accelerate. We need to disseminate the knowledge to everybody in the country as much as possible. It's not only in the focus group, but to all the provinces around the country. And the last is to innovate. Find a way to make the leaders learn and know what is important to them. If we get their support, we can move forward very fast. Okay, next slide. I don't think I have time to explain this. If you have time, go and read this book. It teaches you how to change things, okay? So I would like to say thank you and pass the mic to Dr. Prasit.
Well, thank you so much, Dr. Kasemsuk, for your great presentation. And you are saving 3 minutes for your time allocation. Well, we go to the last but not least speaker from Thailand, Dr. Prasit, who will share about variety of hospital assessment tools. So please, Dr. Prasit.
Good morning, everybody. My name is Dr. Prasit Vuttisuthi Methavi. I'm from Prince of Songkla University. I'm a trauma surgeon, emergency physician, and emergency and disaster management by training. Thank you very much for organizing committee that invited me to share my experience, how the academians like me, like us, to support the MOPH to implement the hospital safety. As we know, and so many people mentioned before, that there are a variety of the hospital assessment tools recently. Next slide, please. And once data from the systematic review over 140 studies, they found that there are 33 studies that use 11 hospital preparedness assessment tools. And it's mentioned that there need to be adaptation or developments of the hospital assessment according to the country context and country health system framework. Next slide, please. So this is the concept and the framework to development of the hospital assessment tool for mass casualty and disaster in Thailand. And this is not only the concept and framework for development, and it's also for implementations, and it's also continuing improvement and the quality assurance and sustainable. The first of all, we assess our opportunity that we don't have any standard assessment tool. We don't have the national standard to assess the hospital readiness for MCI or disaster. So the first step, we need this form or need self-assessment. And the second one, we don't have any data. If you have the national form, we can do the survey at the national survey. And this survey, we can use it as the input for MOPS for implementations and improve the hospital safety for the whole country. And is it better if we can further develop the self-assessment into the scoring system so we can categorize the level of hospital safety in some level, like WHO, at the low, moderate, and the high level. And the last one for sustainability, it is better if we can implement it into the hospital accreditations. Next slide, please. So we gather the experts from emergency medicine and emergency management all around the country, and we have a meeting to have our concept and methodology platform and also the framework. And we do the systematic search over 5,000 abstracts. And finally, we found 76 full paper for analysis. And the framework that we use at our MOPH Health System framework is the basal 6 building block plus. And we categorize the tool according to the 6 building block plus of the WHO. And before we launched this hospital assessment tool, we did the pilot study in 40 hospitals in Thailand, and we categorize the assessment tool into 4 categories. The FMSA is according to the level of our hospital in Thailand. It means the first level, middle level, standard, and advanced. Next slide, please. And this is the final versions of the hospital safety assessment tool. This is the manual that we can use it, and this is the publication. Next slide, please. And the comparison for our hospital assessment tool to the WHO Hospital Safety Index 2015. The first of all, the target that is also to the hospital, and the concept also include all disaster cycle, and also we have the general information. But the hazard vulnerability analysis, we just only mentioned about top 3, not all 40 items that need to be assessed by the HSI 2015. And we categorize our assessment tool according to our hospital level in Thailand into FMSA. Next slide, please. And the module of the checklist, we divide it in 7 modules according to WHO 6 building block plus. That's based on our MOPH health system framework. And our item is just 127 items for the advanced level hospital, and it's only 98 items for first level of the hospital. Next slide, please. So the way forward, we also did the pilot study to do it again, to confirm is it useful for the hospital in Thailand or not. And we also do some scoring system. This is the pilot study that we publications. And it's also, next slide please. Next slide please. We also want to do it to do more concise and into comprehensive hospital assessment tool. It will be only 20 items in 100 score, and this will be more easy and suitable for use in any hospital in Thailand. And also, we also doing the analysis of national survey of our hospital. It's over 1,300 hospitals in Thailand, and it will be publication soon. So this is how academicians like us to support the MOPH to implement the hospital safety in Thailand. Thank you very much.
Thank you very much, Dr. Prasit, for a comprehensive presentation. Introduce us about variety of hospital assessment tools. Well, thank you very much for all speakers for sharing knowledge, policy, program, method, and experience in strengthening and implementing safe hospital in the country. Okay, we now come into a discussion session. I would like to invite all speakers to the stage for discussion. We still have 15 minutes to question and answer session. Okay, so please, are there any question or response from the participant? Yes, sir, please. Introduce your name and to which speakers your question.
Good morning, I'm Eric from the Philippines. First of all, I would like to thank the presenters for sharing your experiences in terms of safe hospital and disaster preparedness as a management. My question goes to Dr. Ina. From Indonesia, I'm sorry.
Okay, Dr. Ina from Indonesia.
Yes. Given that our country, the Philippines and Indonesia, faces the same challenges in terms of number of islands. We have 7,000 islands. You have also around 14 or 17 or 18 islands. So how does your government, in terms of hospital, safe hospital policies and activities, addresses its unique geographical and climatic challenges in order to ensure our hospital or your hospital ready and adequate in terms of responding to any emergencies and disaster? And my second question also may be answered by other presenters. How does your government encourage in terms of innovation and research in safe hospital policies?
Okay. Thank you. Maybe Dr. Ina, you can answer the question about implemented hospital, safe hospital in Indonesia, yeah? Please, Dr. Ina.
Thank you very much. Yes, we have the same as archipelago countries, yeah. We have to make the hospital more accessible and increase the capacity. Not only accessible, but the quality is good. So first, we have especially after the health system transformation, we built some hospitals, especially in East Island, yes, to provide the health services, especially in remote area. We built the newest, I think, in Maluku, yeah. If I'm not, maybe somebody can correct me if I'm wrong. But the first one that we have to build the hospital, make accessible, especially to the remote area. And then we already have the regional referral system. And we have other options like flying health services, and then telemedicine, like that. So how we make the function of health services accessible. So this is not only for emergency situation, but on the daily basis. As we know that daily basis health services is the beginning part that the successful of emergency of disaster situation. If we strong in the daily services, we can get strong in the disaster. But if in the daily basis we are not very good, so I think in disaster we may have some obstacles. So yes, in the normal situation we make the health services, regular health services, accessible and improve the quality, especially after our health system transformation. We have many programs about this, and how to relation with the safe hospital. Yes, of course, to improve the quality of hospital, they must have the accreditation. That's why we the disaster preparedness become one of the hospital accreditation. But still there is challenges. There are challenges like my presentation, because this hasn't been the determining indicators to pass, but still it helpful because it makes the hospital concerned about disaster emergency. That's from me. Thank you.
Thank you, Dr. Ina. And the second question is how government encourage innovation in safe hospital. Maybe every speaker can share the experience in your country, but your government innovation in safe hospital.
Me?
Miss.
Okay. Thank you very much, Sir Eric, for the question. We believe that innovations are supposed to be structured as needs-based and at the same time intra and interagency. Needs-based meaning to say we need to look into the international frameworks and standards and adapt all of the aspects applicable to the country level. And intra-agency, there are innovations within the Department of Health by health facilities, individual health facilities that can be replicated by other health facilities, and intersectoral simply because we have our technical working group who are meeting regularly in order to discuss on what else can be undertaken to improve more the program implementation at the country level. Thank you.
Yeah. Dr. Khairi, please.
Basically, for MOH Malaysia, we do encourage especially our ground personnel to look at how to improve, in terms of their working environment, talking about safety. So we have every year, for example, in my hospital, we have a research week where there are focuses on quality assurance, innovations, and the staff is encouraged to put up whatever activities or ideas they have into presentation, and also if they are if they are become winners during that hospital research week, they will go up to the state level and even up to the Ministry of Health Research and Innovation Awards. So that is how MOH Malaysia actually encourages our ground personnel to go into all this research and innovation, looking at patient safety and safety in terms of the working environment. Thank you.
Yeah, maybe one from Thailand, Dr. Kasemsuk or Dr. Prasit, please.
Yes, based on the research in Thailand about the hospital safety, it depends on the interest of the researchers. But the government have also funding this research. There are many organizations, including MOPS and non-government organizations that can support us to do the research. And we also have the framework that if any researchers are interested in any research about the hospital safety, and MOPS also have the policy that Dr. Kasemsuk mentioned before. We have the ECS that also includes the MCI and disaster management. Some researchers like me, if I am interested to do it, I can submit a proposal to the MOPS for funding or other organizations in Thailand. Thank you very much.
Thank you. Okay, I invite you. Okay, please.
I am Ririk Andri, emergency physician for Serang, Banten, Indonesia. I will ask for all panelists. Our region have a different condition. We have the largest chemical industry in South ASEAN. If tsunami, earthquake and tsunami hit the industrial, maybe 20 million metric ton hazardous chemical will be released. So any regulation, special regulation for specific condition, and what preparation what our hospital must be prepared. Thank you.
Okay, thank you. This question for all speaker about regulation and preparation to cope the impact of chemical industry. Maybe from Dr. Ina first.
Thank you. So I think our regulation about this already reflected in our law and government regulation that the disaster risk reduction must be integrated with our development programs. And then in I think ministerial regulation, and also not only ministerial regulation, but in government regulation, that is stated that every district, cities, and province must conduct the risk analysis of their area, and then conduct the contingency plan. Hospital preparedness and hospital response will be part of contingency plan of the area. So I think there are two kinds of this. Hospital must prepare for themselves, do the risk analysis using hospital safety index or hospital vulnerability assessment, and improve their own hospital and become part of the plan of the area, the plan of the district and cities or province, how to respond together. And because the hospital provide health services will become part of health cluster. So this is not only the responsibility of the hospital, but this is responsibility of the local government. Thank you.
Yes. Thank you, Dr. Ina. Ms. Florinda, please.
Okay, at the country level, we are also discussing about this chemical, biological, radionuclear explosives concern, such that we have the program manager conducting sets and series of the CBRNE training, along with the contingency planning and public service continuity planning activities. I cannot speak more about the other initiatives simply because these are handled by other program managers. But of course, the Hospital Safe from Disaster program is alongside this discussion. Thank you.
Thank you. Dr. Khairi.
Okay. I hope I'm getting your question right. Okay. So basically, we have regulations for example, like chemical producing companies, very strict regulation on how they would manufacture, how they transport all these dangerous chemicals or any hazardous material. But basically, if something were to happen, this is also a multi-agency approach. Yeah, meaning, for example, like for us in Malaysia, at the district level, we have what we call as the district disaster committee, being chaired by the district officer, which will call all the relevant agencies, for example, fire and rescue, police, and other relevant agencies to that specific disaster, even from the hospital or even from the district health office. We have representative there to discuss at the district level, and even at the state level also we have that committee which also discuss and do regular exercises, and up to the national committee. So that's, for Malaysia, that's how we prepare, not just in terms of the regulation, but also in terms of how we would respond to all these incidents. Thank you.
Thank you. Yes, from Thailand, please.
I think the answer will be pretty much the same. It's multi-agency that involved if there's an incident, something like this happen, including the regulation. So in Thailand, if there is some kind of incident, we do have the national disaster plan as seen earlier. We actually divide the disaster level or emergency level into 4 levels. Starting from the highest is the national level, then the regional, then the province, and then the district level. So our response will be dependent on how much is involved in the incident. And if there's a hazmat, it will not only be health, it will be other organizations that take care of the hazmat, such as the search and rescue team, which specialize in that area. So in some sense, it's just a multi-agency response.
Yes. Oh, okay.
In addition, at the country level, we have the Bureau of Fire Protection leading us in the management of hazmat. So there are assigned national agencies mandated for specific hazards. Thank you.
Thank you. Yes, well, every country have its specific strategy to handle and the impact of the chemical industry, and also regulation how to cope with the impact of the chemical industry. Okay, we still have 4 minutes or 5 minutes to another question. Okay, from that side.
Thank you. Good morning. My name Eka. I'm a sociologist from Manado, Sulawesi Utara, Indonesia. My question goes to Dr. Khairi because I think you are a clinical practitioner also. I'm just wondering about the system. Are there any national system or state system, because in your country is divided by state, for anticipating the disaster or massive emergency in order of such capacity and such capability for medical workers or non-medical workers, especially if the disaster affected maybe a little big scale in one region, how you mobilize the medical workers in to work that kind of area, either mobilized by Ministry of Health or just do it by some part of Ministry of Health in your state, or do it nationally. I'm wondering what your system in your country. Thank you.
To which speaker?
Dr. Khairi.
Oh, Dr. Khairi. Please, Dr. Khairi. The question is the national system, how to mobilize human resources and how to make surge capacity in disaster.
Okay, thank you for the question. So, like I said, we have the level of disaster from the district, the state, and the national level. So, if, for example, the situation is can be managed at the district level, so the district health office, together with all the relevant agencies, will be able to mobilize our resources from that district, meaning they are given that authority, to mobilize. But for example, it's a bigger incident, might involve a few districts in the same state. So the state will be the one that will be coordinating the mobilization, because that will be their authority, because they will be the how do you say, the authorized office, to mobilize between districts. But for example, it happens in 2 or 3 states, then the level of authority goes up to the national, to do the mobilization. So they will instruct, for example, something happened in our Kuala Lumpur, Klang Valley area, we can mobilize from the state north from the Klang Valley, or even south from Johor Bahru, the one from Johor, like the map I showed you. So that is their level of authority. But it can be done, meaning we can mobilize. And actually, COVID actually taught us quite something even better. At the time, we mobilized even from the private health care facility, to outsource our regular patient, while some of our hospital become COVID hospital. Then we can really focus our government, Ministry of Health personnel to focus on the COVID, while the non-communicable disease patient can go to the private healthcare facility for management. So it was quite a good experience, even though we hope we do not face that sort of situation again. But it was a good learning curve for us in Malaysia. Thank you. I'm not sure. Thailand?
Already? Oh, okay. You want
to say?
I thought he asked Thailand.
Dr. Khairi, yes. Dr. Khairi? Okay. Yes. Thank you. I think we are in the end of the session too. Thank you for all the speakers. One note for me, Safe Hospital still face many challenges in our country, but we commit to strengthen the Safe Hospital through innovative researches and program and also policy. We give applause to our great speaker this afternoon. Yes. Once again, thank you very much. And back to the MC.
Thank you very much, our moderator of session 2. All the speakers, kindly stay with us on the stage, please, for the presentations of our tokens of appreciations. Once again, what an inspiring session 2 of the pre-conference day, ladies and gentlemen. And may we invite onto the stage to present our tokens of appreciations to our panel of speakers as well as the moderator from ASEAN Secretariat, Mr. Jim Katampongan. Do kindly join us on stage, please, sir. As we now present our tokens of appreciations to express our gratitudes, first of all, may we present to Mr. Prasit from Thailand. Thank you. And the next one, also from Thailand, to Mr. Kasamsuk Yota Samut. In Thai, we say, Kap Kum Ka. And then the next one, may we present to our colleague from Malaysia, Mr. Khairi bin Kasim. Semin Bahasa, terima kasih for your presentation. And next up to Mrs. Florinda V. Panlililo. We present our tokens by saying salamat po. Thank you very much. And our final speaker of the day from our very own Indonesian Ministry of Health, Ibu Ina Agustina Isturini. Thank you very much for your insights on the matter. And for helping us navigate the discussions, our moderator of the day, Ibu Widiana K. Agustin. Thank you very much indeed. And now for a moment of photograph. I do believe we have one more person who joined us initially, which was Ibu Madelina Ariani for the result of rapid review, but she's all the way back there. Ibu Madel, may we have you on stage for the tokens of appreciations? We do have one for you. Let's give her a big round of applause, ladies and gentlemen. Thank you very much for joining us on stage, Ibu Madel. And she was earlier giving us the introductions for the result of rapid review, giving us an overall insights on knowledge and experience sharing in the ASEAN. And now for a moment of group photo. Mr. Jim Katampongan, may we have you at the center, please? Yeah, of the group. ASEAN Secretariat embracing all members of the ASEAN member states. On the count of three, 1, 2, 3, 1, 2, 3. The big round of applause for session 2. Ladies and gentlemen, thank you very much, our moderator and esteemed speakers. As we invite our moderator and speakers, as well as Mr. Jim, to return to their seats, ladies and gentlemen, we almost come to the end of our agenda here at Melia Porosani. In the meantime, before we move on to our lunch, we do have a few announcements to make pertaining our next agenda, which is the observation tour and also your welcome dinner this evening. Ladies and gentlemen, we will begin our visit to the inauguration of the ASEAN Institute of Disaster Health Management in the Faculty of Medicine, Public Health and Nursing of Universitas Gadjah Mada Yogyakarta at 1 p.m. local time. And may we inform you that each group will be accompanied by one liaison officer or DLO. And the LO will be accompanying each group throughout the tour. They will be standing by at the ballroom, or rather the pre-function area of our ballroom at 1 p.m. awaiting you all. And they will be guiding you through your respective buses, as well as to ensure that all of us will stay together throughout the tour in Gadjah Mada University. And we believe that all of our delegates, you have all received a special goodie bag from our committee members. Please inspect that there is a blue t-shirt in the bag. So we hope for everyone to put on the special t-shirt as our attire for the observation tour. Because just for your information, outside is currently 36 degrees Celsius here in Jogja, one of the hottest here on earth, so we don't want you guys to be observing the campus in your suit. So please put on your blue t-shirts, which you can get changed right after the lunch. And once again, at 1 p.m., not at the lobby of the hotel, but at the pre-function area of the ballroom. And with that, ladies and gentlemen, after our observation tour, please bear in mind that we will have an engaging dinner reception and networking session at the beautiful, the historical Sekar Kedaton restaurant. You'll get to witness some of the most memorable architectural designs of the Javanese people and get the sense of the Islamic Mataram kingdom for yourself with some of the most mouth-watering culinary from Yogyakarta special region. So we look forward to seeing everyone at the welcoming dinner. And again, your buses and your LO will be ready at 1 p.m. local time, and your delicious lunch has now been served at the El Patio restaurant where you had your breakfast earlier this morning. With that, ladies and gentlemen, we'll see you in a bit. I'm Rahmat Idris. Thank you very much and have a wonderful lunchtime.